Hello everyone, my name is Ayesha Mian and I am a board certified child and adolescent psychiatrist. I'm currently working at the Afghan University in Karachi, Pakistan, and chair the Department of Psychiatry over here. Today's discussion is going to be on evidence-based treatments in child and adolescent psychiatry. Evidence-based treatment is basically referred to medications or therapies that we use that have scientific evidence that they work in terms of effectiveness as well as safety for particular indications. Um, there are very few evidence-based treatments that are available in child and adolescent psychiatry. In this particular talk, we're going to cover those treatments that actually have ample evidence. We will also talk about the challenges that the field of child psychiatry has faced to work on developing more evidence around the treatment modalities that are used and how we have had to extrapolate evidence from the adult literature to use for our population, which is children and adolescents. There are three objectives that we have for this particular talk. The first one would be that at the end of this particular talk, all of you that are listening to this particular presentation should be able to list the evidence-based biological treatments that are out there available in child and adolescent psychiatry. Should also be able to discuss the psychotherapeutic treatments, which are the therapies or psychotherapies that are used that are used in child and adolescent psychiatry and that actually have evidence to show that they work. The third objective for this talk is that at the end of this presentation, you should all be able to appreciate the role of family and systems-based interventions in child and adolescent psychiatry. In this slide, we talk about the issues or the challenges that come up when trying to develop an evidence base for the treatments that are used in child and adolescent psychiatry. What implies evidence-based? One of the things that is important when we are looking at the treatments available for children and adolescent psychiatry is that have the trials that have been done been randomized controlled trials. Most of the trials in child and adolescent psychiatry have been open trials, and some have not necessarily used the placebo arm. It's important for any evidence base to be created that the trial be randomized controlled, as well as that we have an adequate sampling size. The other issue that comes up is whether the results that we have found are replicated or are independently replicated. What that means is that if somebody else were to do the same study, would we get the same result and show that the same treatment is going to work in another population when used by another practitioner? The third thing that's important is that the treatment needs to be very definable. For example, there needs to be a particular protocol of how the medication dose has been increased that was used in a particular trial and showed positive results. Or when the treatment protocol is around psychotherapy, is there a particular manual that was followed that can now be replicated in the general population? Another issue that comes up in child and adolescent psychiatry is that of representative sampling. A lot of studies actually use very stringent exclusionary criteria when they're defining their study population, as well as the medication dose that was being used. That may not necessarily be representative of what happens in real life, because comorbidity is actually the rule in child and adolescent psychopathology. And it is very rare that we would see a very well-defined disease process that we can then treat with a particular protocol of medication. Another aspect that comes in is that of therapist factor. Sometimes a particular protocol worked or a particular treatment modality is worked because of therapeutic alliance that developed between the practitioner and the patient population. It is very important that any positive result that we see from a treatment modality is independent of interpersonal factor or therapist factors. And that ends up being very challenging. The idea is that whatever treatment has been used can be generalized to most practitioners. The fourth issue that comes in is that of the applicability of adult evidence, which is what we use a lot when treating children and adolescents. The premise that is used often is that of continuation of disease into adulthood, meaning that if a particular child has, for example, a depressive disorder, he is going to develop depression as an adult as well. That may not necessarily be the case, and newer evidence is actually showing that a disease process that happens in childhood may actually be of a different entity than that that is presenting in adulthood. All right, so in terms of biological treatments, we will start with stimulant medications that are used for the treatment of ADHD or attention deficit hyperactivity disorder. The effectiveness of stimulant medications has been very well documented and constitutes the largest body of evidential literature that exists in child and adolescent psychopathology. By the year 1996, there were about 161 randomized controlled trials that had been published that showed the effectiveness of stimulants in ADHD. Out of those 161 published trials, there were 5 that were on preschool children, about 150 that had been published in school-age children, about 7 in adolescents, and the rest of them were adults. Of all the trials that were done, about 65 to 75% patients actually improved amongst the 6,000 patients that were enrolled in these trials, versus only 5 to 30% of patients that improved on placebo. Stimulants have very clearly shown a positive response for core ADHD symptoms of hyperactivity, inattention, and impulsivity. However, in some trials, they also showed that psychostimulants improved compliance towards medications and also reduced aggression in children who were presenting with ADHD symptoms. Medications that are FDA approved for use for ADHD in children and adolescents are methylphenidate for children 6 years and older, and dextroamphetamines for children 3 years and older. Most of the studies have been done on methylphenidates, amphetamines, mixed amphetamine salts, and pemeline. Most of the studies that have been done using stimulants for ADHD have been short-term studies, not lasting longer than 12 months. However, there have been some randomized controlled trials that have been longer. The largest study that has been done, the largest long-term study that has been done has been the NIMH multimodal treatment study for ADHD, the MTA study, that very clearly showed that the stimulants alone and stimulants plus behavior treatments were both efficacious and showed equal improvements in symptoms as long as the medications continued to be taken. Because of the short-acting nature of stimulants, there has been a lot of rigor and interest in developing longer-acting preparations. Some of the older ones that were developed did not show as much efficacy as the short-term preparations. However, the newer ones that have been developed very closely mimic the psychodynamics of the short-term formulations of stimulants and are as effective as the short-term formulations of methylphenidates and dextroamphetamines. There are times when the stimulant medications don't work, they're not as efficacious, or the child who's been put on the stimulant medication starts to have side effects on the medications. We know from clinical experience as well as data that stimulants may cause appetite suppression, and that is often one of the reasons why parents are reluctant to put their child on the medication, or if the child starts to lose weight or has inhibited growth, then we need to look at other options than stimulants. Sometimes stimulants may also cause emotional agitation, they may cause exacerbation of tics, or dysphoria, crying spells, or in very, very rare cases, psychosis. In any event, when we have to look at other options besides stimulants, there are some other treatment modalities that are available for ADHD. One of them is atomoxetine, which is a noradrenergic reuptake inhibitor. It has been shown in trials to be effective in both children and adults. It is FDA approved to be used for ADHD in children 6 years and older. The advantages of using atomoxetine is that it provides a 24-hour coverage. It's a single-day dosing regimen, and it is not drug of abuse. Other treatment modalities that are very routinely used in treating children with ADHD are bupropion or alpha adrenergic agonists like clonidine or guanfacine. In terms of bupropion, which is also an antidepressant, there is a very small evidence base for the use of this medication in treatment for children with ADHD. In one small study that was done by Berickman et al. In 1995, they showed that bupropion was as effective as methylphenidate. Another study published in 1996, which was a multi-site study, however, showed that the effect size was for bupropion was smaller than that for stimulants. However, it tends to be a good choice to use in children and adolescents who have the inattentive kind of ADD and for some reason are not able to tolerate stimulants or atomoxetine. The other option treatment modality that is very widely used is alpha adrenergic agonists like clonidine and guanfacine. There are very few controlled studies that actually show the efficacy of these treatment modalities in ADHD. However, one multi-site trial of clonidine and clonidine plus stimulant medication very clearly showed that the use of clonidine alone or in combination with stimulant both improved tics as well as ADHD symptoms. Guanfacine also has some efficacy data for use in children with ADHD and is now beginning to be more widely used in children who cannot tolerate either higher dosages of stimulants or get side effects on the medication. Okay, so we're going to switch gears a little bit here and talk about the use of antidepressants in child and adolescent psychiatry. The largest evidence that is available in child psychiatry with the use of antidepressants, especially the SSRIs, has been for anxiety disorders, especially obsessive compulsive disorder. In fact, the largest evidence-based or the best evidence is available for pediatric obsessive compulsive disorder, where SSRIs have shown to be very clearly effective and superior to placebo. The FDA approved the use of fluvoxamine and sertraline in 1997 both for pediatric obsessive compulsive disorder. Fluvoxamine has been FDA approved to be used in children in pediatric OCD 8 years and above, whereas sertraline has been approved to be used in children 6 years and above. Other than that, there has also been other smaller studies, especially with fluvoxamine, that have shown efficacy for SSRIs in other anxiety disorders like separation anxiety, social phobia, as well as generalized anxiety disorders. Other than SSRIs, TCAs, especially clomipramine, has also been shown to have superiority over placebo in children with obsessive compulsive disorders. Fluoxetine also has been shown to be superior to placebo in a small study with a sample size of 15 children in cases of selective mutism. Okay, the efficacy of antidepressants for the use of major depressive disorder in children and adolescents has been a difficult issue in child psychiatry. Despite the belief that this is the same illness as adults, it has only been recently that double-blind placebo-controlled trials have actually been demonstrated efficacy of SSRIs in children with moderate to severe depression. There have been a few studies by Emsley in late 90s and then 2003 that showed the superiority of fluoxetine in children with moderate to severe depression. A similar study by Keller et al. Showed the superiority of paroxetine over placebo in children with moderate to severe depression. Another study showed that paroxetine worked better than clomipramine in a study with children who had moderate to severe depression. However, this particular study did not have a placebo arm. Prior studies that have used tricyclic antidepressants have actually failed to show any superiority of antidepressant use over placebo. There have been a number of methodological difficulties with these studies. One has been a very high placebo rate. Also, the children or the youth that were used in these studies had mild depression and not moderate to severe depression. There was also therapeutic effect that we saw out of the concomitant treatments like supportive psychotherapy or psychoeducation therapy. There is also a sense that there may be some developmental differences in drug metabolism and response of children and adolescents compared to adults. Also, perhaps something that has not been researched well has been the possibility of syndromic differences between depression in youth and adults. Regardless, at this point, the standard of care for moderate to severe depressive disorders is at this point the use of SSRIs. This might not be the first line of treatment, which according to ACAP practice parameters for depressive disorders still tends to be therapeutic modalities or psychotherapeutic modalities before the use of SSRIs. However, in terms of medications, SSRIs at this point are the standard of care for children who present with moderate to severe depressive disorders. Okay, the efficacy of antidepressants for the use of major depressive disorder in children and adolescents has been a difficult issue in child psychiatry. Despite the belief that this is the same illness as adults, it has only been recently that double-blind placebo-controlled trials have actually been demonstrated efficacy of SSRIs in children with moderate to severe depression. There have been a few studies by Emsley in late 90s and then 2003 that showed the superiority of fluoxetine in children with moderate to severe depression. A similar study by Keller et al. Showed the superiority of paroxetine over placebo in children with moderate to severe depression. Another study showed that paroxetine worked better than clomipramine in a study with children who had moderate to severe depression. However, this particular study did not have a placebo arm. Prior studies that have used tricyclic antidepressants have actually failed to show any superiority of antidepressant use over placebo. There have been a number of methodological difficulties with these studies. One has been a very high placebo rate. Also, the children or the youth that were used in these studies had mild depression and not moderate to severe depression. There was also therapeutic effect that we saw out of the concomitant treatments like supportive psychotherapy or psychoeducation therapy. There is also a sense that there may be some developmental differences in drug metabolism and response of children and adolescents compared to adults. Also, perhaps something that has not been researched well has been the possibility of syndromic differences between depression in youth and adults. Regardless, at this point, the standard of care for moderate to severe depressive disorders is at this point the use of SSRIs. This might not be the first line of treatment, which according to ACAP practice parameters for depressive disorders still tends to be therapeutic modalities or psychotherapeutic modalities before the use of SSRIs. However, in terms of medications, SSRIs at this point are the standard of care for children who present with moderate to severe depressive disorders. For use of other antidepressants other than SSRIs, there really is not much data that shows any evidence of superiority over placebo or other antidepressants. Bupropion very clearly shows no efficacy in pediatric depression. Other medications like venlafaxine have some small studies that show some efficacy of the medication, but only if used in smaller dosages like 37.5 to 75 milligrams. Both bupropion and TCAs have, in prior studies, shown clearer evidence for use and superiority in ADHD symptoms. Bupropion is used more or recommended to be used more over TCAs because of the side effect profile of the TCAs, including cardiotoxicity. TCAs, especially imipramine, has been shown to be effective in the use of enuresis in children. However, the medication only helps until the time that it's taken and provides symptomatic relief. As I had mentioned in the earlier slides, antidepressants have shown to be effective in some other areas other than pediatric depression. This includes the efficacy of fluoxetine in children with selective mutism. Again, it was a small study. However, clinically, the medication is used widely for children who come in with selective mutism and has shown to have good, credible results. There is also some efficacy for TCAs in children with separation anxiety disorders. Again, as I mentioned in my previous slide, that TCAs have also been used for symptomatic relief for enuresis. The medication is not curative. Bupropion and TCAs are used for ADHD or have been used for ADHD. In that instance, bupropion is definitely the first choice over TCAs. Also, there is some efficacy of the use of clomipramine in children with autism, and it has been shown to be superior over placebo for the repetitive behaviors that are seen in children with autism. All right, now we're going to talk about psychosis or early-onset psychosis and the use of antipsychotics in child and adolescent psychiatry or psychopharmacology. There are actually very few studies that actually examine the use of antipsychotics in early onset psychosis or schizophrenia. And none of those use the atypical antipsychotics that are now the standard of care or the first line treatment for psychotic symptoms. There have been some small studies that have been done in the past. There's one with Haldol that showed the superiority of Haldol in the use of early onset psychosis. Another study that looked at Haldol versus loxapine also found that both of them were superior to placebo in early onset psychosis or psychotic symptoms. There was another study that looked at Haldol versus clozapine in treatment of psychotic symptoms in children and adolescents. In that particular study, even though the sample size was small, there was about 21 patients. Clozapine was shown to be more efficacious. However, it also tended to have more side effects. So as a continuation of the previous slide, most of the evidence that we have of using antipsychotics in children with early onset psychosis comes from adult literature. The antipsychotics have actually been researched a lot more in disorders other than psychosis or psychotic disorders in children and adolescents. These include autism and pervasive developmental disorders, mental retardation, Tourette's disorders, as well as disruptive behaviors. The best evidence that is available in this area has been with the use of risperidone in children with autism. This was a study that was conducted by the Research Unit of Pediatric Psychopharmacology and very clearly showed the superiority of risperidone in decreasing aggression and self-injurious behaviors in children with autism. Now risperidone is FDA approved, is the only medication, psychotropic medication that is FDA approved to treat aggression in children with autism. Very similar data from 30 years ago is available with the use of Haldol, which was also used in children with autism, especially for aggressive behaviors, and showed that it decreased aggression and self-injurious behaviors. None of these medications actually cure the symptoms of autism. There is also significant data in the use of Haldol, thioridazine, as well as risperidone in children with mental retardation. Again, it's symptomatic use to decrease aggression, disruptive behaviors, and self-injurious behaviors. Thioridazine was shown to decrease hyperactivity and conduct problems in mental retardation, while risperidone and Haldol were shown to decrease aggressive behaviors. There is also significant data for the use of Haldol and pimezide in Tourette's disorder. In a study that used both Haldol and pimezide, Haldol was seen to be slightly superior to pimezide to treat tics. However, in another study that was done later, Haldol was not found to be superior to placebo. Clinically, antipsychotics, especially Haldol, is used a lot for reducing tics and tic disorder. Clonidine also has some data and has been shown to be efficacious in decreasing tics in children with Tourette disorder. With regards to other disorders, Haldol has been used in children with conduct disorders, again, to reduce aggression. In a study that was done a while ago, Haldol was found to be as effective to lithium in decreasing aggression and slightly superior to placebo. Another study showed thioridazine to be helpful in reducing aggressive behaviors in children with conduct disorder. A recent study by Finling et al. Showed that risperidol helped in a similar way to decrease aggression in children with conduct disorders. There is some old data that has used haldol, thyroidazine, and chlorpromazine in children with ADHD. Again, it does not improve the core symptoms of ADHD. However, it does seem to reduce aggressive behaviors and hyperactivity in these children. Okay, so now we're going to move to bipolar disorder and manic symptoms and the use of mood stabilizers for these disorders in children and adolescents. Lithium is the only medication that is FDA approved to be used in the treatment of bipolar disorder in children 12 years and older. Study done by Geller et al. In 1998 very clearly showed that lithium improved mood symptoms in children with bipolar disorder. There have also been other small studies that show the clear superiority of lithium and shows that it's efficacious for manic symptoms in children and adolescents with bipolar disorder. Other than lithium, there is no compelling evidence that documents the use of anticonvulsants like valproic acid or carbamazepine and the newer anticonvulsants for bipolar disorder in youth. A study that was done by Del Bello et al. Looked at the use of quetiapine and valproic acid together and found that together they were efficacious for acute mania in adolescents. There are other uses for mood stabilizer or anticonvulsants in children with disruptive behaviors or conduct disorders other than bipolar disorder. So for disruptive behaviors in children and adolescents, there are small studies that show clear evidence of lithium or efficacy of lithium. This includes studies by Campbell in 1984 as well as in 1995. Carbamazepine has also been used for children with disruptive behaviors to reduce aggression and has shown mixed results. There is a study by Donovan et al. That was conducted in 2002 that shows some superiority of valproic acid in children with disruptive behaviors. There is no clear evidence for the use of mood stabilizers in ADHD. There are some results that show some efficacy of carbamazepine in, again, reducing aggression in children with ADHD. However, the mood stabilizers or the anticonvulsants do not work on the core symptoms of ADHD. Right. In terms of other medications that are used in often in child and adolescent psychopathology, include alpha-adrenergic agonists. So there was a large multi-site study that used clonidine and clonidine plus methylphenidate, and very clearly showed that just clonidine alone, as well as the combination of clonidine and methylphenidates, both improved tics and ADHD symptoms. The combined therapy of clonidine and methylphenidate actually worked better for ADHD symptoms than clonidine alone. Other double-blind studies have shown mixed results for tics. One study that was conducted with guanfacine showed that guanfacine was helpful both for tics as well as for ADHD symptoms. With regards to anxiolytics, there is no data that supports the use of benzodiazepines in children with anxiety disorders or anxiety symptoms. As a standard of care, benzodiazepines should not be used in children and adolescents unless there is a specific reason to do that for short-term use. All right, so in this slide, we provide a summary for the biological treatments that have clear evidence base to be used in child and adolescent psychopathology. So, in summary, there is very robust, ample empirical evidence for the use of stimulants in children with ADHD. And also, there is robust data that very clearly shows the superiority of SSRIs in children with pediatric obsessive compulsive disorder. Other than that, there is some well researched support for the use of SSRIs in children with moderate to severe depression and in other anxiety disorders other than obsessive compulsive disorders. There is also support for risperidone, and it's also approved by the FDA to be used in treating symptoms of aggression in children with autism. Other than the above, there is very sparse literature that examines the use of antipsychotics for early onset psychosis, as well as the use of anticonvulsants for use in children with pediatric bipolar disorder or manic symptoms. Lithium has been used and is FDA approved for the use of for the treatment of bipolar disorder in children and adolescents for ages 12 years and above. There is very little literature that actually examines the use of psychotropic medications in children with comorbid conditions, which is usually how children present. So, there is a need to develop more database and more evidence and more empirical evidence around the use of or the superiority of using different biological treatment modalities in children who present with comorbid disorders. There is absolutely no literature that supports the use of polypharmacy in children or justifies it in any way, shape, form possible. So it is best that polypharmacy is avoided at all costs, especially in children with psychiatric psychopathology. All right, so when we look at psychotherapies, up until this point, we talked about biological treatments that are used in child and adolescent psychiatry, especially the ones with robust evidence based. Now we're going to go ahead and look at the different psychotherapeutic modalities that have been used in child and adolescent psychiatry and the evidence behind them. So, for the traditional psychotherapies that have been widely used as psychoanalytic psychotherapy or psychodynamic psychotherapy, they have not been shown to be effective in children and adolescents. Some meta-analytic studies that have been done show some positive outcome with more cognitive-based or behavior-based psychotherapies compared to no treatment at all. It has been shown that for children and adolescents, behavioral treatments seem to work much better and have shown superior results than non-behavioral interventions. So, in terms of cognitive behavior therapy, there is very clear evidence that cognitive behavior therapy works better for depression or depressive symptoms in young adolescents compared to other psychotherapeutic modalities. In severe depression, CBT plus relaxation exercises were shown to be more superior than in controls. CBT with more self-instruction manuals and self-instruction skill training tends to be helpful in children with childhood phobias as well. CBT has also been shown to be effective for other anxiety disorders like over-anxious kids, generalized anxiety disorders, as well as for separation anxiety disorders. There are also some reports that show the benefit of cognitive behavior therapy in children who present with symptoms for obsessive compulsive disorder and post-traumatic stress disorder. So it's very clear that there is robust evidence that shows that cognitive behavior therapy tends to work in children and adolescents as compared to, tends to work better in children and adolescents as compared to other psychotherapeutic modalities. Cognitive behavior therapy has also been shown to have some benefit in children with conduct disorders. In this particular case, this CBT is focused more on problem solving skills, in assertive training skills, in rational emotive therapy, as well as in areas of anger management. These are all areas that are specifically applicable to children with conduct disorders. And when the cognitive behavior therapy is focused more on these areas rather than the areas of cognitive distortions, overgeneralizations that are more pertinent to anxiety and mood disorders, then it seems to have more superiority over placebo in children with conduct disorders. Another kind of therapy that works well in children and adolescents is behavioral therapy or behavior interventions. Um, these have found to be helpful in areas of childhood phobias. They have also found to be very helpful in the symptoms around ADHD, especially when used in the context of the classroom interventions, as well as when it is combined with parenting and teacher training, or behavior parenting and teacher training. Behavioral interventions in multi-site studies, especially the MTA studies, have been found to be less effective than treatment alone. So, in those terms, it seems that medication alone might be a more cost-effective way of treating ADHD symptoms. However, recent studies that have come out have shown that behavioral interventions clearly show superiority over placebo and tend to be very beneficial when used in combination with medications to help reduce some of the ADHD symptoms. In preschoolers, it was very clearly shown that behavioral interventions benefit without the need of medications. What is challenging for behavioral interventions is that it requires intensive parent and teacher involvement, and therefore treatment adherence may tend to be a little bit of an issue. It is based on the psychology of behavior and more classic conditioning and operant conditioning principles, and requires a more consistent, intensive, and long term dedication and commitment from the parents and the teachers for it to work well for children with ADHD or disruptive behaviors. Other psychotherapeutic modalities that are used very commonly in child and adolescent psychopathology, and more so in younger children than in adolescents, is family and parenting interventions. It has very clearly been shown to be effective in children with conduct disorders, and it tends to improve parent child interactions. Also, it tends to enhance parenting effectiveness and reduces coercive interactions between the parent and the child. The focus, as I said before, is usually on the younger child. Patterson's behavioral therapeutic interventions or behavioral family interventions uses more of the operant principles of behavior management. And again, the work is more around contingencies and positive reinforcements that help to reduce some of the disruptive behaviors in these children. Behavior therapy or family therapy has actually also been used in anxiety disorders and has been shown to be effective. Family therapy is also used very commonly in children who suffer from anxiety disorders, depressive disorders, as well as sometimes behavior problems that are related more to the family's contextual circumstances that may be going on at that time. Given the complex nature of childhood psychiatric disorders, it makes sense that for some disorders, especially the complex ones, a multifaceted approach that is used in multisystemic therapy has actually shown to be beneficial in some diseases. What multisystemic therapy does is that it uses a comprehensive intervention strategies which encompass all aspects of the child's life. For conduct disorders, multisystemic therapy uses very aggressive case management. It also uses comprehensive psychiatric services as well as well tailored family interventions. And the idea is to maintain the child within his home and not be placed in juvenile detention centers or in psychiatric hospitals. Multisystemic therapy has actually, especially for conduct disorder, has shown to be a lot more effective than inpatient psychiatric hospitalization, incarceration, as well as using polypharmacy or multiple psychiatric medications. There have been some studies that actually show that the effect of the multisystemic therapy lasts for only about 12 months or so after the therapy is stopped. However, there are other studies that show long-term effects of multisystemic therapy, especially if some sort of maintenance work continues to go on with the child for a number of years.